The clinical question that we designed the TAILORx trial to address specifically was twofold. Really was to integrate the information that we had about the 21 gene assay into our treatment algorithm for women who had early stage hormone receptor positive, HER2 negative, lymph node negative breast cancer, which accounts for about half of all breast cancers in the US, and take the information that we had about the assay and guide treatment. So for those, the 1/3 who had a recurrence score that was either low or high, we assigned therapy. For those who had a recurrence score of 0 to 10, we assigned them to endocrine therapy alone, standard endocrine therapy. For those who had a recurrence score of 26 to 100, we assigned them to chemotherapy and endocrine therapy. And we designed the trial specifically to address the question of what is the role of chemotherapy? Is chemotherapy of any benefit or value in women who have a recurrence score of 11 to 25 in a population who would normally be recommended chemotherapy based on their clinical factors? And what we found was that chemotherapy offered no advantage. Endocrine therapy was not inferior to chemotherapy. The results were the same. We met the primary trial endpoint. The other key findings were that for the woman who had a recurrence score of 0 to 10, a very low recurrence score, that they had only a 3% rate of distant recurrence at 9 years. ESMO members may remember that in 2015 I presented the results of the low-risk registry for the first time at the ESMO meeting for the low-risk group, showing 1% risk of recurrence at 5 years. It's now 3% at 9 years, and we expected to see more recurrences. For the group that had a recurrence score of 26 to 100, we saw that 13% had a distant recurrence despite chemotherapy and endocrine therapy. And again, for the mid-range score, we found no benefit from chemotherapy. However, we wanted to be very sure that there was no subgroup of patients who could possibly be deriving some benefit, even if small, from chemotherapy. And so we did exploratory tests, and we found a statistically significant interaction between age, recurrence score, and chemotherapy treatment, such that for the women who were 50 or under, who had a recurrence score in the 11 to 25 range, where we knew in older women from the trial there was no benefit. In this group of women, if their recurrence score was 21 to 25, again 50 or under, they had about a 6 to 7% reduction in the risk of a distant recurrence, which is about the level of risk reduction you would see in an unselected population. And we found about a 2% reduction in the risk of distant recurrence for those who had a recurrence score of 16 to 20. So at the end of the day, they'll be able to make treatment recommendations with a much higher level of evidence and with a much greater level of precision than they've ever been able to make in the past. For those who are over the age of 50, it's pretty clear there's no benefit from chemotherapy, but the information that we have for the younger woman needs to be integrated and incorporated into a shared decision-making process between the patient and the clinician to make the best possible decision for that individual patient.